Welcome to MedEd's production of ECG interpretation of rhythms and 12 leads. My name is Pam Allen, and the title of this module is Atrial Arrhythmias. So atrial arrhythmias, of course, indicate that the origin of the electrical impulse is within the atria. It can be in the left atria or it can be in the right atria. It is not an origin within the sinus node. So we had other modules discuss normal sinus rhythms, sinus arrhythmias, and now we begin to discuss the site of ectopy, which means that an ectopic focus arises either in the atria, the junction, or the ventricles. So this is about the ectopic focus that arises in the atria. So the types of arrhythmias that we'll be discussing are PACs, premature atrial contractions, non-conducted PACs, atrial tachycardias, and then we'll break that down into unifocal atrial tachycardias and multifocal atrial tachycardias. We'll also talk about atrial flutter and then wind up with atrial fibrillation. So what we have to begin discussing is the mechanisms of these arrhythmias, and actually the mechanism of all the arrhythmias that can develop within the cardiac conduction system. And those are broken down into two types of mechanisms. One is enhanced automaticity, and the other one is referred to as a reentry mechanism. So we'll begin with the rhythms that are due to the mechanism of enhanced automaticity. So enhanced automaticity is pretty much what the term is describing, and that is that there are sites within the atria that develop the property of automaticity. The only areas in our heart that is supposed to have the automaticity is sinus node, junctional, and ventricles. So that is those areas that are normal pacer cells, and the normal pacer cells have the cardiac property of automaticity. Well, due to abnormalities, whether it's drugs, electrolyte imbalances, metabolic imbalances, other conductive cells in the heart can develop this property of automaticity and then begin to try to rule the conduction of the heart. It will take over the normal pacers. So the first one that we'll talk about that is the property of automaticity is the premature atrial contraction, or PACs. First criteria is that the P wave needs to arrive earlier than expected, and that's where the term premature comes in. So what you have is a normal sinus rhythm that's interrupted by an early beat. And we refer to those early beats as extrasystoles. So PACs are extrasystoles, PVCs are extrasystoles, PJCs are extrasystoles. So here you're looking at a normal sinus rhythm. You have narrow QRS complexes. PR intervals overall are normal, except that you've got this QRS complex that comes early. It's an extra beat, extrasystole. And in front of that QRS, that narrow QRS complex, you have a P wave. Now, that P wave may or may not conduct. So we're talking right now about premature atrial contractions that conduct to the ventricles. We'll talk a little bit later about those that do not conduct to the ventricles. So the PR interval of the PAC is usually the same or longer than the PR interval of normal beats. So that's one of the clues that we can look for, aside from the fact that the P wave is not going to be normal. It's usually upright in lead 2, and then it can be variable in V1, but if you compare the PAC, the P wave produced by the PAC, it will not look the same as the normal sinus P waves. And if you think about it, it makes sense. The lead is recording how electricity is traveling through the heart and writes that map. Well, from the sinus node to the ventricles, that directional flow is different than an ectopic pacer that develops somewhere else and as the electricity is traveling through the atria, through the AV junction into the ventricles, that pathway is different. So your P is going to look different. But typically it's upright in lead 2, and in V1 it can be variable. Those are the 2 leads that we usually monitor, and that's why I'm only mentioning those 2 leads. So let's take a look at a couple of examples of PACs. On the top strip, we've got a third beat, QRS complex, that comes early, and the arrow zooms in to focus on the elevation that is between the second QRS and the third QRS. Now you can't really identify clear-cut P wave, can you? It's really looking like a big T, no extra bumps. But if you compare the T wave after the first QRS, right away you should be able to see that the second, quote, T is fat. And that's because it's distorted by the premature atrial contraction that produced a P wave that blended in with that T. So be sure that you look at the T waves and compare. And there's the second one that occurred in a little bit past the middle of the strip. So the second arrow is pointing to a second PAC. Now that's really important because we tend to want to see a PAC that is more like the one that we see in the second strip. And in the second strip, see if you can identify the early beat. And that would be the fourth QRS complex. And then before that, you see this big, tall, distorted looking P wave, and that's more clearly a PAC. But still, it's important that you have to remember that that PAC more than likely is going to land on the preceding T and be distorted. And that's the only evidence of a PAC, like in that top strip, that is the distortion of the T wave. So always keep that in mind. When you see an early beat, look at that T to see if it looks the same as the T waves that you find in the normal sinus rhythm. And then the last strip, you see 3 QRSs and then another early beat with an abnormal P in front. So typically, if the patient is asymptomatic, we don't treat these. Always, whenever there is a sudden onset of arrhythmias, then something is happening. Maybe the electrolytes are out of balance. If the patient's on DIG, always suspect that DIG is the culprit. I recall caring for a patient that was getting ready to be transferred out of the CCU, and she pretty much was having most of the time normal sinus rhythm, and we noticed that suddenly she developed frequent PACs. So we did the normal assessment, listened to her lungs, took her blood pressure, pulse, and lungs were clear. And her PO2 had dropped a bit. And that was the indicator that she was going into failure. Her chest x-ray confirmed that. And one of the causes for a sudden onset of PACs is pulmonary congestion, congestion that produces a lower PO2. So keep that in mind when trying to determine what could possibly be causing a sudden onset of arrhythmia. So lower than normal PO2 is one of the reasons that someone would develop PACs. All right, so then let's go and take a look at PACs that don't conduct. So these are PACs that have an early P wave, like the arrow is pointing to the third P. The red arrow, you can see you have 2 normal sinus beats, then you have a P wave that does not conduct to the ventricles. And most of the time, this has nothing to do with heart block. Don't confuse this with pathological failure of conduction. If that P arrived on time and didn't conduct, all right, then be thinking about pathological failure of conduction. But this P wave occurred early and therefore just found the ventricles or the AV node in refractory, so at that point, if it's absolute refractory, there can be no response to the stimulus. So that's most of the time the only distinguishing reason for having a PAC that's conducted and a PAC that's not conducted is that one P wave lands outside of refractoriness and the other P is within that absolute refractory period of either the AV junction or the ventricles. So up that top strip there are actually two non-conducted PACs. The last portion of that strip shows another P, and you can take a good look at the T. Get used to looking for distortions on the T waves for evidence of atrial activity. And sure enough, we have two T waves in the strip that are distorted, so non-conducted PAC. And I want you to remember one thing. The most common cause of a pause is due to a non-conducted PAC. So when you're looking at a rhythm strip and you suddenly see a pause, automatically train your eye to go to that preceding T wave to see if it's distorted. Just have that as a general rule and a good practice to have, because most of the time it will be a non-conducted PAC. It's the most common cause for a pause. And the second strip also has two non-conducted PACs. I can't really see a separate P wave that didn't conduct, but I do see T's that are distorted. So again, the two arrows are pointing to a sharp appearance of a T, and if you compare it to the normal sinus beats, that's different. Now, you may have noticed that the third QRS is a conducted PAC. So the first two are two sinus beats, and then the third beat has a P wave that came early and it did conduct. So this is a blend of both conducted and non-conducted PACs. All right, so the next thing we want to talk about are what are referred to as focal atrial tachycardias. Now these are tachycardias that occur most frequently in children. They can be transient or sustained, and when they're sustained, another word that you may hear is a term is incessant atrial tachycardia. The focal atrial tachycardia, another term also might be automatic atrial tach. Focal atrial tach, the word focal indicates that there is a focus in the atrium, either the right or the left atrium, that develops the capability of automaticity and then fires in rapid succession. If a focal atrial tachycardia occurs and becomes sustained or incessant, a cardiomyopathy may develop. The other thing to think about is that cardiomyopathy can be the cause of focal atrial tachycardias as well. Now, anytime we talk about tachycardia, we talk about a heart rate of greater than 100. But typically these focal atrial tachs are faster. They're between 150 and 280. Don't get hung up on those exact numbers. Those are just general ranges for atrial tachycardia to be about 150 to 280. Typically that's where they are. The rhythm is usually regular, and it can be paroxysmal. And paroxysmal, that term means sudden onset, sudden cessation. And that's pretty much a term used when you see it start and you see it end. So if you look at the strip below, you see that we have 3 normal sinus beats. Then we have the early beat, where if it were just that beat, it would be a PAC, but it's followed by a lot of PACs. Essentially, that's really what it is. It's just multiple PACs in succession that are occurring at a rapid rate of over 100, but typically in between that range of 150 to 280. And then there's, again, the 2 normal sinus beats. So it suddenly started and it suddenly stopped. So that would be paroxysmal atrial tach or PAT. Then, so the P waves are visible and uniform. If it's only from one focus, they would be uniform Ps. But I have to be honest, when you have a rapid rate like this, it's very difficult to distinguish T from P. So I wouldn't worry too much about trying to separate those two. If you've got the normal sinus T and P, then you can identify the difference. You can compare and see, well, yeah, I can see that during the atrial tachycardia, surely those points are due to the P on top of the T wave. The QRS width is normal, and the ST and T wave, the ST and T wave may be distorted. Well, the T wave definitely will be distorted, and it depends on how fast it is. If it's not so fast, where the T doesn't really marry into the T wave, then you may not see the distortion, but typically they are on top of one another. So here's a case of a 15-year-old female high school student who developed rapid palpitations and dizziness while she was playing soccer. So the EMTs arrived and obtained a rhythm strip, and if you look, it shows a regular, narrow complex. The tachycardia is at a rate of 220, and then it stops abruptly during an attempt to start an intravenous line. So more than likely, starting the IV produced a vagal maneuver and stopped the rhythm possibly. So then she was referred to an electrophysiologist for a workup. It's possible that this young student could very well have an accessory pathway which allows for a re-entry mechanism. All right, now there's another type of atrial tachycardia, or another manifestation of focal atrial tachs, and that's when you have a paroxysmal atrial tach that doesn't conduct all of the Ps. So that's referred to as PAT with block. And sometimes that's a good thing, because if every one of those Ps were conducting, that rate would be very fast. And to have every now and then some of them not conduct can give the heart rate a break. And this is typically found in patients with pulmonary and advanced heart disease. And you know, as we know, most of our patients have some, in today's aging population, and the aging population of our hospitalized patients, that's not uncommon to find that most of our patients may have some degree of heart disease and pulmonary diseases as well. The atrial rate with this type of rhythm is a little bit slower, 150 to 200. Again, just know that it's over 100, and these are rate ranges. They can be faster than that, and it may be slower. So don't identify or discount the rhythm if it's not within that perfect rate range. P waves are visible. As you can see, the two arrows down below on the sample strip are pointing to the Ps that are in between the QRSs where they don't conduct. And as with a lot of atrial arrhythmias, DIG may be the problem. So anytime a patient suddenly develops an arrhythmia and they're on DIG, suspect that DIG could be the problem. And I might mention here that DIG toxicity is a clinical diagnosis. It's not always, and shouldn't be, totally determined by a DIG level. DIG levels can be normal and patients can be toxic. It's whatever their threshold is for that DIG level. Some patients have a very low threshold and some have higher. So a patient who has an above normal DIG level very well may not be toxic. If they don't indicate any symptoms, they have no toxicity. So it's good to monitor absolutely the DIG levels, but when patients suddenly develop arrhythmias and they're on DIG, suspect DIG toxicity. Okay, so we've talked about the focal atrial tach, where you have one area that develops automaticity and tends to be the bad ectopic focus in the atria. Well, now we're going to talk about multiple bad foci in the atria, and that's multifocal atrial tach. And I find this to be a pretty easy rhythm to identify. This again is usually found in the elderly with cardiovascular pulmonary disease. The rate 120 to 200 in that typical rate range. And in order to qualify for multifocal atrial tach, you need 3 or more different Ps. And in many cases, you'll find more than that, much more than that. And I think we can see that as evident in the strip on this slide, where we've got, I see 5, maybe even 6 different looking P waves. So in this case, in multifocal atrial tachycardia, your R to Rs are going to be different, and your PR intervals are going to be variable. And it's not uncommon for the QRS to be abnormal. There's a degree of aberration, meaning that when some of the Ps go through the AV node and get ready to activate the bundle branches, one or the other bundle, either the right or the left bundle, may still be in a state of repolarizing. And so for that one beat, there is a temporary bundle branch block, and that's just due to refractoriness of all of these Ps bombarding the AV node in bundles. So it's not uncommon to see some degree of aberrancy in your QRS complexes with multifocal atrial tach. Now in this case, on the slide, we don't see that. All the QRSs are shaped the same. All right, so let me show you another example of a multifocal atrial tach. This actually was a patient who was DIG toxic and unfortunately became toxic due to an accidental overdose of IV DIG. And so it slowed the response rate to the Ps, but produced the multifocal atrial tachycardia. And here you can also appreciate the 2 different shapes of QRSs. So here's an example where there's some degree of slowing through the bundles. There's a lot going on here. The rate is very slow, has some pauses, and as soon as the DIG is out of the system, the patient will return to a normal sinus rhythm. So it depends again on how they're tolerating it. You may need a DIG binding drug, Digibind, to correct this problem. So management strategies, it's difficult to treat, very difficult to treat. You have to stop the DIG, we talked about that. Beta blockers are used, calcium channel blockers may be used. Amiodarone and sotalol have been successful in the suppression of the focus, but sometimes if it's an incessant and keeps reoccurring, a catheter ablation would be the next thing to use. So cardioversion, when the patient is not tolerating, cardioversion is your first option. But that would be, first of all, rate control is always your #1 goal. But if the patient is hemodynamically compromised, then cardioversion would have to be your first option. And then the catheter ablation if it continues to be an ongoing problem. All right, so this is these arrhythmias that we just talked about, again, to recap, focused on one ectopic site in either the left atrium or the right atrium, either one. The other mechanism that we're going to talk about now is going to be what's referred to as reentry. And this is responsible for most of the clinically significant arrhythmias. So the reentry tachycardia, if someone has a SVT, it's usually going to be due to a reentry mechanism. And what reentry means, it's a continuous, repetitive propagation of an impulse that travels a circular path return to the site of origin. So let me try to make that a little bit more clear. So let's say that the reentry occurs within the AV node. So what would happen is that, let's say a PAC occurs. the PAC, the electricity that was generated by the PAC arrives in the AV node. Okay? And that AV node has pathways. And those pathways don't all recover at the same time. So what can happen when an early beat gets to the AV node? There's pathways that have recovered and there's pathways that have not recovered. So what happens in that case is that the impulse will go antegrade. Antegrade means forward conduction. The impulse from the PAC will go antegrade to the ventricles. And then as the electricity is getting on down into the ventricles, those original pathways that were not completely repolarized have fully recovered and now can accept electricity. So now the impulses can fire also retrograde. So you've got impulses that are going forward and backwards within the AV node, and that's referred to as reentry. And it's very easy to handle because it's sensitive to vagal maneuvers. So sometimes just having a patient cough can stop the rhythm. And I know that probably all of us at some time when we've had too much stress, too much caffeine, have PACs. I know I can tell when I have skip beats, and more than likely they're PACs. So what happens, and I have felt this myself, is I'll have an early beat and then all of a sudden I feel like my heart is racing, and then I take a breath in and that maneuver is enough to just stop the rhythm. So if you feel that your heart is racing sometime, just take a deep breath, do a Valsalvo, cough, and that will more than likely stop it. And then you have to start thinking about, well, what was I doing that precipitated that rhythm? But that's reentry, and that's the most common cause of arrhythmias. There are other terms that you may hear used are called reentrant excitation, reciprocating tachycardia, circus movement, reciprocal beats, echo beats. The echo beats meaning that it goes back and just makes noise again by depolarizing the atrium. So these are all terms that refer to arrhythmias that have reentry, that are due to reentry. So let's talk about the first atrial arrhythmia that occurs due to reentry. And this is atrial flutter. Now, atrial flutter doesn't circulate within the AV node. Atrial flutter has a site within the atrium that is circulating. And atrial flutter has an atrial rate of between 280 and 320. Now, this is an important rate range, because when you're trying to distinguish, well, how do I know it's not atrial tachycardia? There's a lot of P's and they're firing at a fast rate. Look at the heart rate. If the atrial rate is less than 280, it's atrial tachycardia. When the atrium starts firing at 280 or more, the P waves take on what has been referred to as a sawtooth pattern. And that's the only reason that those P's have that appearance, is because of the heart rate. Now, the sawtooth pattern, it's important to remember this, is apparent in leads 2, 3, and AVF. They're not sawtooth in all your leads. So 2, 3, and F, and the slide that's up now shows AVF, and you can see that sawtooth pattern. And the sawtooth pattern in those leads is caused by the atrial impulse, the P waves, coming so close together that the isoelectric shelf begins to depress a bit. So you've got that sawtooth appearance. Now, in V1, you don't see sawtooth. So if you are looking at a V1 lead, and down below on that strip, on the bottom portion, there is an atrial rate that's very close to 300. So it doesn't matter the appearance of the P. It's the atrial rate that determines flutter. Now, to confirm that flutter, go ahead and take a look at lead 2 or 3 or AVF. Leads 2, 3, and AVF, they all look at the inferior portion of the heart, so they look very similar. And you will see that there'll be sawtooth. Just don't rely on sawtooth to help you determine whether a rhythm is flutter or not. Use your atrial rate as well. 2 to 1 is the most common ratio, and 2 to 1 can be very difficult to identify. So whenever you see a rate of a ventricular rate of exactly 150, suspect 2 to 1 flutter. Because if you have a ventricular rate of 150 and you have 2 P's per every QRS, that's an atrial rate of 300, and that would be qualifying for flutter. Atrial flutter is an unstable rhythm. You don't want your patients in flutter because there is first of all, 2 to 1 flutter is 150 beats per minute. That's fast, and many of our patients won't tolerate that. But there's also the possibility that if that atrial rate, maybe drops down from a 300 to a 280 to a 290, now they may be able to conduct 1 to 1. So it's not a stable rhythm. It's the most common rhythm after AFib. It's most of the time, about 30% of the time when it develops, it's due to coronary artery disease. Hypertension would probably be responsible for another 30%. And some have no evidence of heart disease, and that's probably the remainder of the population, no evidence at all. So when you see a 4 to 1 flutter, which is in the case below, then it's a good idea to be thinking that there's probably some physiologic block of why there could not be more conduction than just 4 to 1. Now, you're more than likely looking at the bottom strip and saying, well, I only see 3 P's. Why is that 4 to 1? Well, you have to always assume that there's a P hidden in the QRS, and if you take your calipers and you march the P's out, you will see that 1 does fall in the QRS. So really the best way to determine the ratio of flutter is to get your ventricular rate, and this is around 75, and the atrial rate is around 300, so that's 4 to 1. So take your ventricular rate and divide it into the atrial rate, and that'll give you your ratio. So if you have a ventricular rate of 150, 2 to 1 flutter, because your atrial rate is more than likely around at 300. So again, sawtooth P waves and leads where the QRSs are positive, and those more than likely are going to be your inferior wall leads, 2, 3, and AVF. But in leads where the QRSs are negative, you'll have upright Ps. But those Ps that are seen in this V1 on the slide, they are not going to be just like the sinus Ps that the patient would have if they're a normal sinus rhythm, again, because the origin of electricity is different. It's not coming from the sinus node, which would map out a different pathway. All right. Here's an example of 3 to 1. 3 to 1 is not very common. Most of the time, flutter is in a 2 to 1 or a 4 to 1. And then at the bottom, we have 4 to 1. All right, the next type of reentry mechanism is atrial fibrillation, and it is the most common sustained arrhythmia. And atrial fib, it's been said that it doubles the risk of sudden death compared to normal sinus rhythm, doubles it. Most patients who develop atrial fib have structural heart disease, although it can be completely idiopathic, have no rhyme or reason to why a patient would suddenly develop AFib. Alcohol may precipitate AFib. We used to call this holiday heart syndrome. AFib would be seen in the ED following, let's say, New Year's Eve. You might see an increase in patients coming to the ER with complaining of rapid heart rate and finding out that they may have binged a little bit too much the night before. So AFib can be caused by higher than normal intake of alcohol. With AFib, you have a chaotic ventricular rhythm. In AFib, your atria is firing over 300 times per minute, 320. So really, let's think about these rate ranges that we've discussed so far. Atrial tach up to 280, flutter 280 to 320, fib 320 or more. So that's the only difference between atrial tach, atrial flutter, and atrial fib is atrial rate. And when the rate occurs within those parameters, the P's take on different appearances. So you don't have any well-defined P's with AFib, and therefore the ventricular rhythm is very chaotic. So now we have an example of AFib. You can look and see that you have what's often described as a wavy baseline. Now, if a patient has atrial enlargement, then they may have what's described as a coarse AFib. So AFib can be fine, medium, and coarse. And I would describe this as a fine to medium AFib. A medium would be where you can see the fibrillatory waves. Fine would be almost like a straight line. And then coarse would sometimes somebody might say, well, that looks like a fib flutter. Well, your heart can't fib and flutter at the same time. And remember, that's a fibrillation and flutter are distinguishable by atrial rate. But what can happen is that some patients can, and I've seen this many times actually, patients have a run of fib, then their atrial rate slows down, then they go into flutter, it speeds back up, so they can go in and out of flutter to fib, flutter to fib. But just because you're not sure which one it is, you can't call it fib flutter. So a coarse atrial fib may trick the eye into thinking it's a flutter, but take a look, because flutter is typically regular, AFib is definitely never regular. It's impossible for over 320 atrial electrical impulses bombarding the AV node to be able to get through on a regular basis. So it's always going to be irregular. So comparing these two tracings, you've got normal sinus rhythm up at the top, and then down at the bottom we have AFib, and it shows the irregular QRSs and the fibrillation waves in between the heartbeats. And so the total rhythm is just chaotic. There's no pattern to it. And I would describe this as a coarse, medium to coarse AFib. If somebody has right atrial enlargement or left atrial enlargement and they develop fib because their atrium is already hypertrophied, then more than likely they would have that coarse AFib. So for acute onset in managing atrial fibrillation, rate control is always your number one goal. And it's always your number one goal pretty much in managing any arrhythmia, because the rate is going to determine the patient's hemodynamic status. For rate control, beta blockers, calcium channel blockers, DIG, diltiazem, another popular drug used. For some patients, cardioversion is necessary immediately. Think about anticoagulants. When the atrium is fibrillating, it's not really contracting, it's just quivering, and the blood can pool in the atrial appendage, and then especially following a cardioversion, an embolus they can throw an embolus. And it's always important to rule out an MI, which can be the precipitating factor for atrial fib. So for persistent AFib, there's a lot of research and a lot of discussion about is your goal rhythm control or is the goal rate control? Always these patients are on anticoagulants. For rhythm control, flecainide, propafenone, amiodarone, dronedarone, and sotalol and dofetilide have been used, and with variable success. And ablation is becoming more and more the the way to go, because so many of the drugs that we give these patients are such that they precipitate more arrhythmias. And then the ablation is very successful in what they do when you have re-entry, and that's, remember, AFib is due to re-entry. And with AFib, they cut in and produce scarrings that keep the electricity from activating those areas where the scars are made, and then so the electricity cannot continue in this circular motion. It's very, very successful. Now, the last thing that we'll talk about is, I think it's the last thing, wandering atrial pacemaker. Now, wandering atrial pacemaker is not anything that we get worried about. We don't treat it. No management is required. It's where, again, there are more than one site in the atria that develops the property of automaticity, but it fires at reasonable heart rates. So you really cannot, again, expect your QRSs to be regular, because the QRSs are responding to the atrial impulse. And it's unlikely that multiple atrial sites would be firing at exactly the same heart rate. So what this looks like is just a sinus irregularity and different looking P's. So it's not atrial tachycardia, which you would have different looking P waves. And if this heart rate went over 100, then yes, that would be atrial tach. And by looking at the P waves on the slide, I would say it would have to be multifocal atrial tachycardia. Okay, so there's one P wave, there's another different one, and there's a third P wave. So yeah, if this were faster than 100, it would definitely be a multifocal atrial tach. Well, now it's time to test your skills. So this would be an opportunity for you to interpret the rhythm strips that are on the slides or in your handouts, and then I will give you the answer. So here are the first three, and we'll go over these. All right, the first one is sinus rhythm with 2 PACs, the third QRS, and looks like the 7th QRS are PACs. And then the second one looks like multifocal atrial tachycardia. You've got a tachycardia, have to have a tachycardia, and then you have P's that are different shapes. The third one is a regular rhythm with a sawtooth pattern between the QRSs. This ventricular rate is 75, and therefore this is a 4-to-1 atrial flutter. On this one, the top strip is atrial fibrillation. The second one is a paroxysmal atrial tach. If you can see the beginning and or the end, then you can identify and use the term paroxysmal, PAT. If the strip is only tachycardia, then you don't know if it's persistent, incessant, so you just have to call it atrial tach. Now, if I only saw that first half of that strip, I would have to say just SVT. I would say it's probably atrial because the rate's pretty fast, but compared to a junctional tachycardia. But really, when you can't identify clear-cut P waves, then you have to say it's SVT. There's nothing wrong with saying it's SVT. It's SVT because the QRSs are narrow. If the QRSs are wide, then it's ventricular tachycardia. And the last one begins with 3 sinus beats, followed by a non-conducted PAC. Remember, The most common cause of a pause is a non-conducted PAC. All right, so that concludes the atrial arrhythmias, and don't hesitate to email me if you have any questions. Thank you.